Good evening, everybody. Thank you very much for having invited me to talk about a topic which is very close to my heart. For two of my current affiliations, one, of course, being member of the governing body of the International Committee of the Red Cross. The International Committee of the Red Cross being one organization which has very clearly in its strategy 2017-2019 made the fight against sexual violence, the support to women affected by sexual violence as one of their strategic priorities. I think it's one of the few organizations who has made that commitment. And on the other hand, actually in collaboration with the ICRC at the center I direct at the University in Geneva on education and research and humanitarian action, we are one of the few centers, I think actually the only academic center in the world, who has dedicated courses to teach about sexual violence in conflict settings and how to address this issue. And we do that in collaboration with many humanitarian partners. So it is really based on these interactions I have also with many practitioners from the field, and then having myself looked into what do we know about this topic that I'm able to give this presentation tonight. So I was told how this works. I hope I'm able to. Yes. Now, it may be a topic you are very well aware of. It's difficult for me to know because, of course, it is not really human reproduction. This is, I would say, the negative side of the medal, is what can happen to women when they're exposed to violence and even may become pregnant as a consequence of rape, which means against their will. Now, these are just some data from WHO, who did for the first time, I think, in the history of mankind, started about 10, 12 years ago to do worldwide country surveys on the issue of women experience sexual violence by a partner or a non-partner. And you can see that anywhere in the world, women are exposed to this. Now, the issue is also how do we define sexual violence? And as you can see here, I will not, of course, read this, which is the commonly accepted, I would say now, definition of sexual violence. It is really relatively broad because it is any sexual act or attempt to obtain a sexual act, unwanted sexual comments or advantage, etc. Sexual violence in armed conflict, from the ICRC perspective, it means we focus particularly on sexual violence in conflict as well in detention, and focusing on sexual violence and not other types of gender-based violence. I'm not going to go into all the terminology, but of course there's a broader field out there which is violence directed against women because they are women, but which is not specifically sexual violence. And there are agencies who tackle the whole issue, looking at education of girls, etc., and there are organizations who work in humanitarian settings who particularly focus on the issue of sexual violence. When we talk about the types of sexual violence, what obviously immediately comes to mind is rape, and I will come back to the issue of rape, but there are many other forms of sexual violence, and there may be some here, depending on which part of the world you come from, which are not very evident to you, like forced marriage, levirate marriage, etc., or female genital mutilation, which is particularly prevalent in some African countries. But all these are forms of sexual violence. Now to come to the issue of rape. This is an international rape scale. It's horrendous to think that we have something like that. But it shows data which are not from yesterday, because this was scaled in 2011, the prevalence of rape in different parts of the world, and you can clearly see that there are some countries which are much more affected than others. Although since 2011, I'll very briefly come back to this, of course, we have a huge increase in sexual violence and in rape in the Middle East. What do we know about sexual violence in conflict settings? Before we tackle a problem, we want to know what is the magnitude of the problem. The magnitude, it really, although we know that this has existed ever since humankind has engaged in wars, it really only came to the attention of the international community in the 90s. It started during the Rwanda genocide and post-genocide, where there were horrendous numbers of women raped. then in Sierra Leone during the Civil War, in Liberia during the Civil War, and then, of course, much closer to home for us, when there was the war in ex-Yugoslavia, and it was very much known that rape was used as an instrument of war. So these things brought the attention, created a first awareness, I would say, and then more systematic surveys were done in the 90s. Now, if one looks at a meta-analysis of these surveys, which were done in a wide range of countries, as you see here, and this was among female refugees in humanitarian emergencies, you see that there is an amazing range between 4.4 and 83% of women that have experienced sexual violence in this emergency situation. Now, very clearly, the average doesn't mean much in this case, and it's very likely an underestimate because we know that reporting of sexual violence is extremely difficult. Another systematic review only found 10 studies. What they found, interestingly, is that in emergency situations, the rates of intimate partner violence are higher than rates of wartime sexual violence. It's very difficult to compare these studies, methodologically extremely different, very small sample sizes often, response rates are often very low, recall periods are not comparable. So just to tell you that we have numbers, but that they probably don't tell us the real story. We should also be quite careful about preconceived ideas, and I'm here citing 2 studies from Africa, one in Côte d'Ivoire, which was done after the last civil conflict. And you can see that in the past 15 years, women had experienced more sexual violence from the intimate partner than by combatants. On the other hand, also in the same survey, it was found that 6% of men had experienced sexual violence in their lifetimes, which is something which we're not often thinking about. In Liberia, it was also interesting that former combatants, which we often perceive as the perpetrators, actually had experienced higher rates of sexual violence than non-combatants, meaning that combatants themselves are exposed to a very high level of sexual violence. Just to let you know that the legal framework is very clear. As we know, legal frameworks are only one part of the equation and don't prevent crime from happening, but it is absolutely prohibited under the international human rights law at any time, and this is clearly prohibited under the international humanitarian law, which applies to international and non-international armed conflict. So why is it that sexual violence persists or increases often during armed conflict? There is a climate of impunity, and although some little things have been done, you may remember some of the cases which were judged by the International Criminal Court, but also that some people were released very unbelievably, actually. So this climate of impunity is still there. There is a failure often inside armed groups to provide clear orders of instructions. We also have a proliferation of small arms and light weapons, which allows men to threaten women in these situations. There, of course, are increased vulnerabilities, and when you see the picture of this woman, which was from the Democratic Republic of Congo, she is alone. She has to go to her fields. She has to support her family. She has no protection and lives in a community where they are surrounded by armed groups. And communities are destructed, so individual coping mechanisms are also much less than what you have in a normal situation. Now, I can probably go very quickly over this because here I probably speak to an audience who knows this very well. Sexual violence leads to death for all these reasons and these reasons. One of the big issues in some of the countries where HIV/AIDS prevalence is high is, of course, the transmission of HIV during rape, and, of course, other serious injuries, and then certainly things like murder during rape or for honor, which means a woman who has been raped will be murdered afterwards because this happened to her and she can no longer be accepted in her community. And then infanticide of children born of rape. It is also, there are several studies which have looked at what happens to victims of sexual assault. 3 times more likely suffer from depression, 4 times more likely to contemplate suicide, post-traumatic stress disorder, abuse of alcohol, and abuse of drugs. So you see, besides the physical injuries that could lead to death, a whole host of psychological issues that would need to be addressed. And the social and legal consequences can be extremely severe because in most communities, women who have been raped are not considered necessarily as a victim, but are considered as themselves being at fault for something and are no longer accepted by their families or can no longer marry, lose the guard over their children, etc. So extremely severe social consequences. So when you think about the consequences and what can happen to women in these situations, you can already see that certainly medical care is one very important issue, but that medical care alone will not do it. At the same time, you need both psychological and social support. You have to think about the legal and judicial ways of addressing the issue. And then, of course, there is the issue of security and protection. And we should also remember that a woman who has once experienced sexual violence may again be exposed, particularly if she stays in the same context, and that preventing it means also preventing the second, the third, and the fourth time happening. We have seen women in certain contexts for whom this has become so normal that they are being raped that they don't even consider it anymore as a crime. Now, to address a problem, which I think we have identified, is do we know what works? And here, in a scientific audience, I must say the evidence is small, and we don't have extremely good evidence on what works, I insist, in emergency and conflict settings. We know a little bit more what works in settings like Italy or Switzerland. Even there, sometimes we don't know exactly how to go about it. So here I just refer to two big studies. One very big study which looked at all the evidence, all the published papers between 1990 and 2011, and it was very clear that the evidence is relatively poor and that what we know about impact of initiatives is very limited. And this was reconfirmed by a special report in The Lancet in 2014. Now, medical care, we know what we have to do. So this is probably the best set standard. And here we have clear evidence why we need to do it. We need to do the vaccinations, we need to do HIV prevention, we need to do psychological first aid, etc. But here the main issue is accessibility of care. And for those who can really look at the slide, you can see that this is the 5 essential services proposed by MSF, Médecins Sans Frontières. As Professor Berghauser said, I also have a long story with the other very big humanitarian organization, Médecins Sans Frontières, Doctors Without Borders. They are probably the organization who has accumulated the largest experience in medical care for victims of sexual violence and have very clearly shown that the big issue is accessibility. Now, why is accessibility such an issue? First of all, people need to know that there are services they can access and that they really will get treatment. There is a huge risk of safety for people, and there is a big issue if it's known why they go and seek medical care and they do it for sexual violence, that there can be retaliation, stigmatization, etc. And the other thing is, of course, that in these situations, often medical infrastructure is damaged or destroyed, and it's difficult to have trained medical staff available. So can this access be improved? There is really only one good study in Nairobi in a slum which clearly showed that, yes, it's possible. Although I would say this was a stable setting in a very tense and resource-poor setting, but still it wasn't an armed conflict area. But it's interesting that they were able to show that the main elements are geographic proximity, that a clinic is open 24 hours a day so that people can come at night, can whenever they need to come, and that the clinic was well respected, well established, and they had a very clever system of allowing people to come to the clinic without saying, I need to get attention for sexual violence. What you see on the left-hand side are two studies which were done in South Kivu in the Democratic Republic of Congo, which you know has sometimes been called the country of rape, where during the whole post-Rwanda genocide situation and the civil war which then happened in that part of DRC, sexual violence has been absolutely rampant. And you see here that the mean time between sexual assault and seeking care is on average 10.4 months. And this is a very well-established hospital which has a wonderful clinic for sexual violence survivors. So it tells you something about the difficulty of accessing care. And that, it's so important that women can come within 72 hours to get emergency contraception and to get HIV prevention, but only 3% of survivors show up within this time. So stigma and taboo is probably the major issue to address to improve access to care. And there are different ways of trying to do this, but the first thing is very important, that health providers themselves very clearly don't label and stigmatize people who come. Now, what about psychological support? This is an image, again, of DRC, where the ICRC has implemented over several years now a program to provide psychological support to victims. The issue of psychological care is you have to provide it at 4 different levels, and often we focus only on one of these levels, sometimes on the specialized services, sometimes on strengthening community support, and one often doesn't think that one has to provide services at all these different levels. Because if somebody has a severe post-traumatic stress disorder or a severe depression, you really need psychiatric service. It's not enough to provide first psychological aid. When you look at the evidence, and there were some meta-analysis and some studies done, again, the evidence is relatively weak because the interventions are very different. And for those of you who come from the domain of psychiatry or psychological support, you know that there can be different approaches, and that, of course, it's much more difficult than in the medical care side to be prescriptive. Length of treatment is another issue. Women often come only once. You only have one chance to do something for that woman. They have a great difficulty coming back 3, 4, 5, 10 times. And then the level of health professionals who provide that help may be very different. Another issue is that the evidence supports practices that are relatively complex, because those were really sometimes even examined in randomized controlled trials, but very little evidence for what is mostly done in the field, which is psychological first aid and community-based support. Now, when I come to legal support, the picture is even bleaker in terms of evidence, because we know only how difficult it is for people to access legal services and how difficult it is to establish legal services which truly cater to the needs of the victims, and that it's very difficult to improve this access. The best example probably of how this could work better is what one now calls the one-stop shops. This was again experienced for the first time by a very creative gynecologist, Dr. Mukwege from the Democratic Republic of Congo. Perhaps you have heard of him. He has done an amazing job over the past 15 years in trying to, first of all, help directly as a gynecologist women who are severely harmed by sexual violence. But he has then had really the intelligence, I would say, and the courage to start to add all the other services which are needed, which means the psychological services, then the social economic support, and then the legal aid, and that what one now calls in this field the one-stop shops, showing that clearly this makes it much easier for women to access the services than if they have to go to 4, 5, 6 different providers telling their same story over and over again. There have also been examples. The American Bar Association supported mobile courts in some places, particularly again in DRC. It's quite expensive, it works, but it's not sustainable in the long run. The issue is also there is an increased number of cases filed now and of prosecutions, but it's not clear if this is really helpful to the survivors. And often survivors actually don't want to go for the legal court. I know that here we are mainly talking about women, but just a very brief word about men, because we now know that men are also victims of sexual violence. I could talk a whole hour on that, will not, but we know that if one looks into it, you find it, and an organization in Uganda who does quite amazing work for victims of sexual violence got aware of the fact that men did not come forward, but when they started to give the opportunity to men to talk about it, it became clear that 1 out of 3 victims of sexual violence is actually a man. And of course, ICRC, working a lot in detention centers, we're extremely aware of the issue among detainees. Again, extremely difficult to do something about it, but one has to know it. And in Uganda, there were men who for 20 years had anal lesions due to rape, which they had never been able to come forward and ask for help. So this refugee law project in Uganda is what I still know as the only project really specifically also, not only, but looking at the issue for men. Now just very briefly to close, what is ICRC doing given this relatively scanty evidence we have? Perhaps one of the most important things is the bullet point which is at the bottom, which is the reversal of the burden of proof. What that means is there was a time when one would say, well, if we don't have evidence that sexual violence is there and what the numbers are, then we don't need to do anything. And it's very clear that this is totally the wrong approach because people will not come if you don't provide services. And they will not self-declare as victims of sexual violence. So it has been totally turned around and saying we know that in any situation where we work, there are high loads of sexual violence, so we have to start to do something. And then after a while we may be able to say what are the numbers, how many women and men are coming forward, etc. It's to have this multidisciplinary and comprehensive approach I pointed to earlier. I'll just briefly mention which elements ICRC is involved in. And it's the particular focus on sexual violence. In terms of health response, of course, it's the first assistant. It includes also the psychosocial services. It mainly works by supporting national medical structures and personnel. ICRC often doesn't implement the medical care themselves. And then what is very important is to conduct community-based awareness sessions, because it's only if the community accepts that this is going on and they start to be supportive to victims and survivors that you will really improve also access to services. As you may know, ICRC has also a strong role in protection. It is one of their two main arms. So documenting patterns of abuse and violation is extremely important. For them, it's also what they call the confidential dialogue with authorities and armed forces and weapon bearers, including also training of weapon bearers on what is legal, what is not legal, how they should go about it and what they should not do, working with at-risk communities and individuals, as I already said, and then preventing and addressing sexual violence in places of detention. I think it's one of the rare organizations who does that systematically in all their detention places where they work. ICRC also provides economic support and often tries not to target victims of sexual violence because that's another way of stigmatizing them, but in communities where there are high rates of sexual violence, trying to address the needs of those women to allow for social reinsertion and reducing their future vulnerability. And of course, transport costs, as we saw, can be a big barrier to access to services, so that's another thing provided. And then, of course, using communication, and here I just mentioned three of the contexts where ICRC has worked for quite a long time now on the issue of sexual violence. It's also important to raise awareness through the media. It is important to look how is this reported in the regional media and perhaps to influence some of that reporting. And then it's also to disseminate information about the activity and the services available. To finish, the main challenges ahead, this is just my very personal point of view. What is clear is that most of the evidence we have and the experience we have are from African settings. And this is a huge issue because now we have an extremely high burden of sexual violence in the Middle East, Syria, Iraq, countries surrounding Syria, Iraq. And we have heartbreaking stories of things happening and health professionals or other humanitarian workers being absolutely unable to address the issue because the culture is so different from the African culture. You can't just translate what we have learned there to a setting like Syria or Iraq. So we need to learn much more how to adapt what little we already know to those contexts. Organizations need to think outside their silos to provide a full multidisciplinary response. Nobody can do it all alone. And that's another thing which organizations start learning, how to work together, how to coordinate on this issue, really acknowledging that one can't do it alone. And of course, we need more solid evidence. There's much room for research there, and hopefully a lot of that will come up in the coming years. Thank you very much.